Dear ladies and gentlemen, dear faculty members, thank you very much for having me at SAGES 2022. I would like to present, as Dr. Shader said, the assessment of pyloric sphincter physiology after IL-Esophagectomy using the endoflip method. I myself am a resident, senior resident at University Hospital in Cologne, which is a university hospital, and we do a lot of esophagectomies, around 250 per year. In this slide you can see my disclosures. As you can see, I have nothing to disclose. Also, in the field of surgery, the pyloric function plays a crucial role after esophagectomy. The most common functional problem and complication in around 1/3 of the patients is delayed emptying of the gastric conduit, called DGCE. DGCE is associated with a reduced quality of life, an increased morbidity, and prolonged hospitalization. However, DGCE can also lead to a series of adverse events, like pneumonia, anastomotic leakage, and prolonged ICU stay. The pathophysiology of DGCE is not fully understood. However, the obligatory dissection of the vagal nerve and the altered anatomy of the gastric conduit are proposed to be contributing factors. There are several diagnostic tools in order to prove the patient has DGCE, like chest X-ray, water-soluble contrast radiogram. However, none of these diagnostic tools evaluate the pylorus itself. One novel endoscopic approach to evaluate the pylorus is the endoflip method by Medtronic, as you can see here in this slide. So it measures, as you can see, diameter. It measures the balloon pressure, the distensibility, and the volume of the balloon in order to study the biomechanical properties of gastrointestinal sphincters. The distensibility is calculated by dividing the cross-sectional area in square millimeters by pressure. Endoflip measures the impedance planimetry with real-time images. As you can see on the left picture, the endoflip has mostly been used for the assessment of the lower esophageal sphincter. In our study, however, we want to focus on the pylorus. The video on the left, you can see a typical endoscopic view of a patient suffering from DGCE. The pylorus is very spastic, and you find a fluid collection before the pylorus. The right picture demonstrates the endoflip measurement in our clinic. We use the endoflip catheter EF 325M. This catheter is lubricated and then inserted orally alongside the endoscope. The correct catheter positioning was continuously confirmed through the endoscopic vision, as you can see in the little picture below. And correct positioning was also verified with the shape of the pylorus represented as a narrow segment with a decreased cross-sectional area on the screen. You see it later. The balloon was inserted throughout the pylorus, positioning the pylorus in the lower third of the balloon. After correct and stable positioning, the endoflip was initially filled with 30 milliliters of saline solution, and then in additional 5 millimeter steps up on the final filling volume of 50 milliliters. After every 5 millimeter step, we did a 30 seconds intermission to allow stable measurements. There are only a few studies available who focus on pyloric distensibility after gastric surgery. One of them is a French study group around Desprez et al., and she first described the distensibility of healthy volunteers and compared it to patients suffering from dyspeptic symptoms after gastric surgery. And you can see the distensibility measurements in healthy volunteers and symptomatic patients after esophagectomy. So we performed a single-center analysis of our own experience as a national high-volume center of the surgery for the gastrointestinal tract. So we compared patients suffering from DGCE after esophagectomy to asymptomatic patients, also after esophagectomy, in order to know if the endoflip measurements is feasible. We performed a retrospective analysis from May to October 2021 at our university hospital. We were able to include 70 patients after esophagectomy. 51 patients had no signs of DGCE, and 19 patients suffered from DGCE. On the right, as you can see, I promised the endoflip measurement of a DGCE patient. You can see the reduced distensibility of around 3 and the very spastic pylorus represented as the narrow shape with a reduced diameter as well. To the results, the patient's characteristics were similar between the two groups, as you can see in the table in front of you. However, the UCC stadium 3 was more common in DGCE patients, and the retention of food in the endoscopy was also more common in DGCE patients. Then, as a second step, we wanted to know how the quality of life of patients suffering from DGCE is affected. So we chose to do the gastroparesis cardinal symptoms index score, called GCSI. This is a questionnaire which focuses on important symptoms related to gastroparesis, like nausea and vomiting, fullness and bloating. And as you can see, DGCE patients significantly suffer more often from these 3 symptoms. Then we wanted to know how DGCE is affected or is affecting the quality of life of patients. We showed the PAGI quality of life score. This score contains 30 items like daily activeness, clothing, the relationship, and the diet. And as you can see, patients who have not suffered from DGCE have a significantly higher quality of life. And then we focused on endoflip measurement and wanted to know how is the distensibility in patients suffering from DGCE versus patients who have not DGCE. We focused on 3 balloon filling volumes, 40, 45, and 50 milliliters. And as you can see, the distensibility is significantly reduced in DGCE patients. And for us, it was a good tool in order to diagnose the patients. The highest significant difference in diameter and distensibility was measured at a 40 milliliter balloon filling, proving to be the most reliable filling level. So now I want to come to my conclusion. Endoflip measurement is safe and feasible in a large cohort of patients after highly standardized oncological surgery resulting from esophageal cancer. We could demonstrate that the distensibility in asymptomatic patients is significantly higher than in patients suffering from DGCE. So, as I said, for us, it was quite a good tool to diagnose these patients. However, we need more prospective trials to further evaluate and identify the selection criteria for this diagnostic method. So thank you very much for the attention. As you can see, here's the Cathedral of Cologne. Thank you very much.